بسم الله الرحمن الرحيم. نحن اليوم راح نكمل الموضوع السابق اللي احنا وصلنا، يمكن اخذنا fracture olecranon, fracture distal humerus in adult, intra-articular fracture, and today we will discuss fracture of radial head, one of the common injury, and we face it in the emergency department, and it is very easy to miss this fracture. So what about a fracture of radial head? This fracture is common in adult. In children, it is much less than in adult. In children, usually we face a fracture through the neck of radius, not on the head. So the fractured head of radius usually seen in adult. The mechanism of injury for this fracture, usually a fall on outstretched hand. The patient presented with history of fall on the ground, while the elbow in extension position and the forearm in pronation. The head is impacted against the capitellum. So this injury, fall on outstretched hand, either cause a fractured head of radius or fractured capitellum due to impaction of the head of radius against the capitellum. Classification of radial head, it is called Mason classification. We have 4 types of Mason classification. Type 1, it is undisplaced vertical split. Type 2, displaced single fragment of the head. Type 3, it is comminuted fracture of the head of radius. And type 4, lastly, associated with elbow dislocation. As you see in this picture, this is for type 1. It is very clear fracture without displacement, without displacement. And for type 2, a fracture through the head with separation of the segment. And type 3, it is comminuted head radius of fracture. And for type 4, fracture head of radius associated with elbow dislocation. Other picture show the Mason classification. It is here very clear. It is vertical split without displacement, displaced fracture head radius, comminuted fracture head radius, it is type 3, and type 4, it is usually associated with elbow dislocation. Treatment for a fractured head of radius, very important to know about the treatment of fractured head radius. First of all, conservative treatment, rest in collar and cuff for 3 weeks and give analgesia. And then after that, start physiotherapy movement of the elbow joint as the pain allow. And it is indicated in type 1, that is undisplaced fracture, and in type 2, if the fracture involve less than 1/3 of the head of the circumflex of the head of the radius, and in the outer part, not in the inner part, in the outer part. So this indication for conservative treatment. A single displaced large fragment, it should be reduced by open reduction and fixation by K-wire or by headless screw. A comminuted type 3 fracture, this is a challenging. So if the medial collateral ligament interosseous membrane is intact and there is no association with coronoid process fracture, radial head excision can be done. Radial head replacement may be needed in some cases. After treatment, POP in 90-degree flexion for 1 week and then converted to sling for 3 weeks. As you see in these different pictures, this is the site for exploration of the radial head through the lateral side, and we go directly to the radial head and reduce the segment and then fixate it by plate and screws or by headless screw. As you see here in this picture, this is what we call a headless screw or Herbert screw, and this is anatomical plate designed for fracture of the proximal radius and head of radius. As you see in this picture, if we have an intact interosseous membrane, you know the interosseous membrane that connect the radius to the ulna, we can do sometimes excision of the head of the radius if there's intact of the interosseous membrane and medial collateral ligament. Sometimes radial head arthroplasty done for unstable fracture and associated with medial collateral ligament or with interosseous membrane rupture. And this is the segments of the prosthesis of the radial head. Complication of radial head fractures. First of all, any intra-articular fracture may be associated with stiffness of the joint. So stiffness is a common and may involve elbow and radio-ulnar joint movement. Myositis ossificus is an occasional complication. Recurrent dislocation of the elbow if medial collateral ligament is injured. Now we go to other important subject. It is elbow dislocation. Also, this common in adult, and it forms about 20% of joint dislocation. It is less common than shoulder dislocation or finger dislocation. That is more common joint to be dislocated. Also, you must know the classification of elbow dislocation. The commonest type is posterior type. Also, we sometimes face anterior type that associate with olecranon or process of fracture. Medial dislocation, lateral dislocation, and divergent dislocation. All these are rare. Posterior or posterolateral dislocation, it is more common. Usually the patient presented with history of fall on outstretched hand while the elbow in extension position. Clinical diagnosis is very important. It is important and it may associated with a neurovascular injury, median and near ulnar nerve injury. Sometimes it's associated with a brachial artery injury. The clinical presentation, the patient presented with history of fall on outstretched hand, as I said, pain, swelling, and ecchymosis, and loss of function of the elbow joint. This is the common mechanism of injury. Fall on outstretched hand with the elbow joint is in extension. So the elbow head of radius and the olecranon diverted posteriorly and leading to dislocation of the elbow. This picture, it's very obvious. There is clear deformity around the right elbow and the prominence of the olecranon due to dislocation of the elbow from its place. This picture shows the size of dislocation. This is the posterior dislocation. Anterior dislocation usually happen if there is association with the fracture of olecranon. We have lateral dislocation and medial dislocation, and lastly divergence between the radius and ulna, and all these are rare except the posterior elbow dislocation. This picture, this X-ray, show posterior elbow dislocation. In AP view, no comment on the site or on the type of dislocation. So we need a lateral view to know the diagnosis and to exclude associated injuries. Treatment for elbow dislocation. Uncomplicated cases of elbow dislocation, that I mean there is not associated with a fracture of the head of radius or fracture of olecranon or coronoid process. So close reduction under general anesthesia by traction and countertraction of a slightly flexed elbow, correction of lateral displacement, and usually we need olecranon to be pushed forward with two thumbs of the surgeon to reduce the elbow to its place. Dangerous thing is the entrapment of median nerve during the reduction of the elbow dislocation. And sometimes there is associated trauma or injury to the brachialis muscle, and this enhances the possibility of myositis ossificans. After reduction, The arm is put in collar and cuff. No need for POP usually or bag slab, but need for sling by collar and cuff with elbow flexed for more than 90 degrees for 3 weeks. A complicated cases that associated with the fractures, sometimes elbow dislocation associated with coronoid process fracture, with radial head fracture, olecranon or medial epicondyle fracture, and this is treated according to the fracture associated with the elbow dislocation. Complications of elbow dislocation. First of all, vascular injury, brachial artery or vein, compartment syndrome, common during elbow dislocation, if not treated early, nerve injury, like median nerve and ulnar nerve injury, and reduced dislocation. Late complication, myositis ossificans, stiffness, recurrent instability or dislocation, and lastly, osteoarthritis. Any question regarding the elbow dislocation or radial head fracture? معنا طلاب ولا ماكو حد؟ واضحة، it's clear. نعم. أريدكم تعرفون أنه types of posterior of elbow dislocation here, the commonest one is the posterior type. And also about radial head fracture, the Masonic classification very important. Okay. Now I will discuss the fracture around elbow in children. The previous lecture I discussed the fracture around elbow in adult, اللي هي intra-articular fracture humerus, distal part of the humerus, fracture olecranon, fracture head radius, a fracture of elbow dislocation. Sometimes in adult we face coronoid fracture. It is much better than olecranon or radial head fracture. الكورونيد process هو الجزء الأمامي anterior part of the proximal part of the humerus. But sometimes we face it, and I will not discuss in this lecture. So, fracture around elbow in children, we have 7 types of fracture and dislocation around elbow in children. The most important one is the supracondylar fracture of the humerus in children. Also, we face a lateral condylar fracture, medial epicondylar fracture, fracture medial condyle, medial epicondyle, and medial condylar fracture, usually the same things, but the difference in the site of the fracture. Fracture separation of the distal humeral epiphysis. It is very similar to the supracondylar fracture. The difference between the fracture separation of the distal humeral epiphysis or physis is the fracture happened through the epiphyseal plate, while in the supracondylar fracture, it is above the epiphyseal plate. Fracture neck of radius, very important. And lastly, pulled elbow. One of the important subjects in upper limb injury is supracondylar fracture of the humerus. It is very common in children. And according to displacement of the distal segments of the fracture, we have a 2 type. So we have a posterior displacement of the supracondylar segment and rarely anterior displacement. This picture shows the site of the fracture where it happened. A fracture through the distal part of the humerus above the epiphyseal plate. It is the commonest site. Also see is in this picture. This is the epiphyseal plate. This is the yellow line. And the fracture usually happens above the epiphysis, above the epiphyseal plate. Posterior type, as I said, it is the commonest type. It is about 95% of cases. It occurs due to fall on outstretched hand again. The humeral break just above the condyle. the distal fragment is displaced backward, and because of the forearm usually in a pronation position, so the distal segment twisted to inside inward displacement. The ends of the proximal fragment may injure the brachial artery or median nerve. Anterior type, it is rare. It is due to direct trauma on the elbow with the joint in a flexion position. For posterior type, we have a classification called Gartland classification. Again, we have type 1, 2, 3. Type 1 for undisplaced fracture. Type 2 for mildly angulated fracture with posterior cortex is still in continuity with the bone. For type 2A, less severe and the distal fragment angulated. For type 2B, more severe than type 1, and the distal fragment angulated and rotated. For type 3, so it is completely displaced fracture. This picture shows the type 1 is undisplaced fracture, type 2 with angulation, or sometimes type 2B angulation and rotation. For type 3, it is displaced fracture. Clinically, usually the child presented with history of fall or stretched hand. The child is complaining from pain, swelling, and deformity. Very important deformity is called shape deformity in displaced posterior type. So the S-shaped deformity, we find it not in all types of supracondylar fracture. It is a clinical sign of displaced or type 3 supracondylar fracture. Very important is to check the distal pulsation and capillary refilling. And very important here to exclude the important complication that sometimes we face it in supracondylar fracture, is compartment syndrome. Also, we must check the nerve for any injury. The common nerves, again, here to be injured, it is the nerve. The ulnar nerve injury, it is usually iatrogenic after surgical intervention. As you see here in this picture, it is very clear clinical sign. It is this pain, swelling, ecchymosis, and the S-shaped deformity around the elbow joint. Pain, ecchymosis, swelling, and deformity called the S-shaped deformity. Again, also here, there is a severe swelling around the right elbow with S-shaped deformity due to type 3 displaced supracondylar fracture. X-ray very important to prove the diagnosis. The fracture is seen clearly in the lateral view. In undisplaced fracture, sometimes the fracture not appear clearly. So we concentrate on what we call a fat pad sign, or what we call cell sign, which is a triangular lucency in front or behind the distal part of the humerus, and this will raise the suspicion of the fracture. As you see here, this is the fat pad sign positive. It is an radiolucency in front or behind the humerus. Here it is very clear, and also here it is also clear. There is no fracture line appear in this X-ray, but the fat pad sign positive, and the clinical presentation, the patient presented with history of fall on the ground, swelling, loss of function, and local tenderness on the distal part of the humerus raised the suspicion of the supracondylar fracture. In AP view, sometimes in MID or in type 2 fracture, we can measure what we call the Bowman angle, which is helpful in assessing the degree of medial angulation of the distal segment, and it is normally less than 80 degrees. What we mean by Bowman angle? The moment we draw an imaginary line that passes through the shaft of the humerus, and the other line through the epiphyseal plate of the lateral condyle. And then we measure the angle. It is usually less than 80. If the angle is more than 80, 90, or more than 100. So is mean that the fracture displaced and medially or internally rotated. Also, this picture diagram show the fracture site with hematoma formation around the fracture site and separation of the fat pad, and also there very clear fat pad sign positive. And this is a different picture of type 3 displaced supracondylar fracture. Also, again, type 3 displaced supracondylar fracture. As you see in AP view, it is not so clear, but in lateral view, it is very obvious. Complete displacement of the supracondyle segment. Sometimes we face a compound of fracture, supracondylar fracture, but it is compound, and sometimes the bone exposed. Treatment for supracondylar fracture. For undisplaced type 1 fracture, the elbow is immobilized at 90-degree flexion and neutral rotation in a back slab for about 10 days. And after 10 days, we change it to POP, and checking X-ray is very important to exclude a displacement. Never ever to apply a back slab or foot cast in extension position in a fracture of elbow. Usually we need a 90-degree flexion of the elbow joint to immobilize the fracture. For type 2 posterior angulation fracture, manipulation under anesthesia sometimes of great helpful to us. The traction with counter attraction and correction of the sideways tilt and rotation. The flexion of the elbow to 120 degree. Then we must check the radial pulsation. If it is negative, then do a gradual extension till pulsation become positive. Because if we put the elbow in 120-degree flexion, it is more stable. But sometimes we face that the brachial artery or the distal pulsation become negative. So very important to check the distal pulsation. If it is negative, then do gradual extension until we gain the positive distal pulsation. After reduction, apply a back stab and checking X-ray. So after 10 days, a full POP, and do another or another X-ray to check the position of the fracture site. Unstable fracture after close reduction, sometimes need close percutaneous spinning by K-wire, and usually we need fluoroscope control to help us in reduction and in fixation of the fracture. If manipulation and close reduction fail, then open reduction and fixation by smooth K-wire. For type 3, completely displaced fracture, again, in children, manipulation under anesthesia, that's mean close reduction, then a close spinning under fluoroscope control. In type 3, we go directly for fixation after reduction under fluoroscope. Or sometimes we fail by close reduction, so need open reduction and fixation by K-wire. Indications for open reduction: failure of close reduction in open fracture and compound fracture, and those associated with the neurovascular injuries. As you see here, during open reduction, we usually do a cross K-wire, but in a close reduction, usually we apply the K-wire from the lateral to the medial. Why? Anyone can tell me why we can apply the K-wire from the lateral direction under close reduction and percutaneous K-wire؟ ليش نخليها من اللاترال للميديال؟ وبالاوبن ريدكشن نستعمل الكروسنج K-wire as you see here.
أنا أقول على مود الأنجل مال الجوينت.
Angle of the joint we can correct it by fluoroscope. You can control it by fluoroscope. أشعة موجودة عندك داخل العمليات، السكرين يسمونه. Then so we can control the angulation. But why we apply the K wire from the lateral? I'm afraid from put it in from the medial under close
دكتور
reduction.
هنا اكو نيرف ممكن
Yes,
يتأثر.
yes. The ulnar nerve. Where is the site of the ulnar nerve? It is on the medial side. So it is very easy to injure it. Very easy to injure it. While in open reduction, usually the first step is to isolate the ulnar nerve. We do exploration of the ulnar nerve, isolation of the ulnar nerve, and then you can easily apply the crossing K wire. It is more stable here. So in in close reduction and the fluoroscope control, usually we need 2 or 3 parallel K wire. But in open reduction, usually we apply a crossing K wire. In expert surgeon, they can do or can apply the crossing K wire also in the close reduction under fluoroscope control. But it carry a lot of complication منها انه هي injury of ulnar nerve. اذا ذكرتكم نحن بدايه المحاضره او بدايه الموضوع كان الميديان nerve injury is the commonest nerve injury during supracondylar fracture. Ulnar nerve injury sometimes happen, but it is usually iatrogenic during surgical intervention. يعني الجراح هو او الطبيب هو اللي يسوي injury للulnar nerve. But the median nerve usually associated with supracondylar fractures. Sometimes, not usually, sometimes associated. Complication of supracondylar fracture. First of all, vascular damage. Some of the supracondylar fracture, like this compounded fracture, okay, may associated with injury to a brachial artery or brachial vein. Compartment syndrome is very, very common after supracondylar fracture, and we must keep our eye on this complication. You know the details about compartment syndrome. It is very important. It is cut of the blood supply or an increase in the pressure in the osteophyseal space that inhibit or decrease the capillary perfusion of the muscle and leading to severe swelling and an increase in the compartment pressure to a limit that lead to ischemia of the muscle. As you see here, due to compartment syndrome, there is severe blistering around the forearm, and you must solve the problem before the complete vicious circle by fasciotomy. Nerve injury again, it is median nerve and sometimes iatrogenic ulnar nerve injury. Late complication of supracondylar fracture, very important late complication, is called malunion. Malunion, uncorrected side tilt or angulation and rotation lead to deformity. Mainly varus deformity. It is called cubitus varus. I think Dr. Farouk discussed it with you in the previous lecture. And it is disfiguring and called gunstock deformity, which is permanent deformity that need to be treated surgically. Sometimes a valgus deformity happen in supracondylar fracture, but it is rare than cubitus varus. As you see in this picture, this is typical cubitus varus or gunstock deformity of the right elbow joint. Elbow stiffness. The elbow is liable for stiffness after supracondyle or after elbow dislocation. So the stiffness is one of the late complications. Myositis ossificans. Passive physiotherapy is contraindication in myositis ossificans again because it makes the condition worse and aggressive myositis ossificans. Aggravate, sorry. So it is advised to active physiotherapy later on. Fracture of lateral condyle of the humerus. This fracture occurred due to fall on outstretched hand with the elbow in extension and forced into varus direction. It is very important mechanism of injury for lateral condyle of the humerus. The elbow in extension and forced into varus. So it is type of avulsion fracture of the lateral part of the humerus. The fracture piece, although it looked small in X-ray, but in fact it is large, and it is pulled by extensor muscle of the wrist, which attached to that side. In severe cases, the piece is rotated by the action of the extensor muscle and become capsized, lead to non-union later on if not treated. This is two examples of the fracture lateral condyle of the humerus. How we know the site of the lateral condyle? It is usually face the head of radius. Lateral condyle fracture in complete displacement due to action of the muscle that attached to it. It is the extensor muscle. Usually try to pull the segment away from the fracture site and rotate the segment. As you see here, it is called capsized. Capsized. And here it is minimally displaced a fracture lateral condyle of the humerus. Again, the child complained from severe pain with history of trauma. The elbow is swollen and deformed. Tenderness at the lateral side of the elbow joint. Ecchymosis sometimes appear and loss of function of the elbow joint. Treatment: if there is no displacement or minimal displacement, we can do back slab above elbow in 90-degree flexion and the forearm put in neutral position. After 7 days, we repeat the X-ray for checking if there is more displacement or not, and then change the back slab to POP for at least 4 weeks. Follow up by active physiotherapy. Displaced fracture usually need upper reduction and internal fixation by K-wire. So, lateral condyle fracture of the humerus, if it is displaced, it carries 3 indications for upper reduction. First of all, it is an intra-articular fracture. Second, it is a fracture attached to muscle, the extensor muscle. The third indication, it is type 4 Salter-Harris injury. It carries 3 indications for upper reduction in displaced lateral condyle fracture. Upper reduction by K-wire. Never ever use a screw to hold this fracture because it is epiphyseal plate, and if you cross it by a screw, it will end by deformity due to arrest of growth of the epiphyseal plate. Complication: late complication of lateral condyle fracture. It is malunion called cubitus valgus. Non-union, this complication is inevitable if the distal piece is capsized and not treated. This will lead to non-union and affecting the growth of the distal humerus. Ulnar nerve palsy, sometimes associated with lateral condyle fracture after malunion, and severe cubitus valgus lead to stretching of the ulnar nerve, leading to ulnar nerve palsy. Fracture medial epicondyle of the humerus. It is occurred due to fallen outstretched hand. The medial epicondyle is avulsed by effect of the strong flexor muscle of the wrist. If the elbow joint is dislocated or subluxated, even momentarily, the fracture piece may enter the joint. Clinically, history of trauma, pain, and tenderness with the swelling. Sensation of the and power of the fingers should be tested to exclude ulnar nerve damage. As you see in this picture, it is type also of avulsion fracture. The fracture affecting the medial epicondyle of the humerus. Treatment: this fracture is extra-articular. It is different from lateral condyle fracture. So minimal displacement is neglected. If the piece is entrapped into the joint, then it must be freed either by manipulation under anesthesia, or if we fail, so we must do open reduction and usually need a fixation by a K-wire or screw. Complication: early ulnar nerve damage, late stiffness of the elbow. Other important subject, fracture neck of radius in children. Again, it is occur after a fallen outstretched hand, force the elbow into valgus and pushing the radial head against the capitellum. In children, it is usually occur in the neck of radius, while in adult, again, it is occur in the head of radius. Clinically, pain in the elbow and localized tenderness on the radial head. Pain on rotation of the forearm is happening. We have three types of fracture neck of radius. First of all, a fracture with angulation less than 30 degrees, and the other is type 2, angulation of the neck of the radius more than 30 degrees, and lastly, the type 3, it is complete or severe displacement of the fracture. Again, here, it is a fracture type 1, angulation less than 30 degrees, and also this picture shows that the angulation is more than 60 degrees, and here it is complete displacement of the fracture site. The treatment in children up to 30 degrees of radial head tilt and up to 3 millimeters of the transverse displacement is accepted and treated by bag slab with deflection of the elbow to 90 degrees. Displaced fracture for more than 30 degrees, then it is need manipulation under anesthesia in elbow extension and traction and varus force applied by the surgeon and try to push the fragment back into its place by the thumb of the surgeon. If we fail by this maneuver, then we must do open reduction and fixation of the fracture site. Radial head should never excise in children. This is very important, not like in adult. In a fracture, even in complete displacement of a fracture neck radius, radial head never excised in children because it affects the growth of the radius bone. The other subject called pulled elbow. In children, the elbow may be injured by a pulling on the forearm while the forearm in a pronation position. It is called subluxation of the radial head. It is really subluxation of the orbicular ligament that hold the head of the radius, which slip up over the radial head. This is the common injury in children when the parent try to pull the child in extension position, causing subluxation of the orbicular ligament that hold the radial head to its place. Clinically, the child is 2 to 3 years old, presented with painful elbow. A history is that the child is being jerked by the arm and crying out of pain. On examination, the forearm is held in pronation and extension and resist any kind or any supination movement. X-ray usually normal, but we must take an X-ray to exclude associated injury or fracture. Treatment, a dramatic response or dramatic disappear of pain is achieved by forceful supination and then a flexion of the elbow. Supination and deflection of the elbow. So the ligament will go back to its place and a feeling of the click under the thumb of the surgeon. Any question for now?
دكتور
نعم.
displacement type 3 اللي هي الاس ساين
Supracondylar.
supracondylar. دكتور
Yes.
الكابيتس فارس همينة كانت supracondylar. دكتور هي نفس الاس ساين هي نفس الجونستوك او كأنه ما حسيته تشبهها بالصورة حتى لو ما هي نفسها.
يعني السوبراكوندايل فراكتشر بالاكيوت برزنتيشن يجينا باس شيب ديفورماتي. بالاكيوت برزنتيشن اذا نرجع للصوره الاولى هذه يجينا الاس شيب ديفورماتي. واضحه عندكم؟
اي واضحة دكتور.
هذه نسميها الاس شيب. هذه بالاكيوت اذا اليوم انكسر غدا انكسر زين يجيكم بهذه الصوره. and swelling, emesis, S-shaped deformity. يجي البيشنت complain of severe pain, loss of function. بينما إذا تقارنوها بالصورة الأخرى اللي هذا الطفل اللي عنده deformity بتشوفون انه هو smiling ويحرك ايده ما مهتم. هذا due to malunion. It is called cubitus varus. الاسم الثاني لcubitus varus الجونستوك deformity اللي هي late complication of supracondylar fracture due to malunion. واضحة؟
اي واضحة دكتور.
هذا جواب السؤال كي انه هو cubitus varus هي نفس الجونستوك deformity وهي نفس malunited supracondylar fracture. Usually presented with cubitus varus. Sometimes يجينا with cubitus valgus بس اقل نسبتها من الكيوبيتاس فارس. So الكيوبيتاس فارس deformity هي malunited supracondylar fracture. اوكي؟ شو يحتاج السيفير تايب اوف كيوبيتاس فارس اور جونستوك deformity؟ شلون نعالجها؟
دكتور هي كوزماتيك أكثر شيء، بس نعمل له
هي
أوستيوتومي.
usually not affect the function of the elbow.
نكسر العظم يمكن ونرجعه.
نعم. But يعني it is ugly deformity. ف we can correct it by doing a distal humeral osteotomy or supracondylar osteotomy. Not opening the fracture site. We cannot reduce the fracture site again. But we can do osteotomy. زين. يسموها الكلوز ويدج osteotomy to correct the deformity of the distal humerus. osteotomy نقصد بها قص عظم، يعني نكسر العظم we do iatrogenic fracture through the bone. Other question. كلش مهم السوبراكوندال فراكشر، يعني انت بتعرفون ديتيلز ماله كله. سوبراكوندال فراكشر، fracture radial head, neck radius also important. pulled elbow very important. صور دكتور فاروق عم نطاك من pulled elbow بالمحاضرة مال Orthopedic. Any question؟ كان نزلت لكم فيديو عن الفراكشر ايبونيم وشعتموا بالموقع. طلاب معي بالجوجل كلاس روم نزلت لكم قبل يومين ثلاثه يعني فد موضوع حكيت في الفيديو قصير او موقع بس فراكشر ايبونيم. لو شعتوا طلعتوا عليها؟ نعم. ايش رايكم بيها؟ فهمتم شيء منه؟ هي تتشابه بس هي نحن هسه نحكي باسماء. راح تسمعون اسماء مثلا كوليز فراكشر، سميث فراكشر، بارتن فراكشر، شوفير فراكشر، بوكسر فراكشر، كل وحده بها اسم. فاحنا نقول كوليز فراكشر راسا نحن مبرمجين ايش نعني بكوليز فراكشر، ايش نعني بمونتيجيا فراكشر. راسا تيجي ببالنا ايش عندك وات از ذا دايجنوستس مونتيجيا فراكشر، راسا تعرف ايش القصه. بس من وين جت هاي الاسماء؟ هي اسماء علماء. فانا شفت فيديو كلش مرتب قمت نزلت لهم الرابط علينا مشون عليها تقرب لكم كثير الفكره. مين جت البانكارت ليجن مثلا، مين جت الهل سايك ليجن، فيعطيك التفصيل يعني مرتبه كلش الباوربوينت اللي منزليها. زين اطلعوا عليها تفيدكم كلش. الفراكشر ايبونيم هي اسماء الكسور باسماء العلماء اللي شخصوها. فوات از ذا اوبجكتس اوف ا فراكشر ايبونيم؟ هذا ما مطالبين بها يعني انتم كمحاضره يجيك من فراكشر ايبونيم او كسؤال، لا بس تعرفون الاسماء هي من جد وبعدين بالديتيلز ان شاء الله. So our objects about this talk it is a radiographic recognition of a common fracture pattern. Overview of a fracture mechanism and associated radiographic finding. A brief history and background information on a source of a fracture eponym. فهي تعطينا ايش هي وين جت. First of all, this is fracture eponym. احنا بنشوف هذا الاكس راي راسا we called this a fracture by the name of the surgeon that prescribed this fracture. So this a fracture called, anyone can tell me اللي كان داوم عملي عندنا؟ Yes, Colles fracture. Colles fracture. What is Colles fracture? It is generally resulted from fallen out stretch hand. It is a transverse fracture of the distal radius with dorsal displacement of the distal segment. It is 50 to 60% of cases have associated ulnar styloid process of fracture associated with distal radius. The displaced type, the patient usually presented with deformity called dinner fork deformity. Colles fracture, it's come from the name of the surgeon that described it, called Abraham Colles. It is an Irish surgeon, or sorry, anatomist, and this fracture accurately described by Colles in Edinburgh Medical and Surgical Journal in 1914. In 1814. What is this? A fracture. Smith. Garden spade deformity. Smith fracture, it is a transverse fracture through the distal part of radius with volar angulation or displacement of the distal piece. So it is reverse Colles. اسم Smith fracture هو reverse Colles fracture. The deformity called garden spade deformity. So Smith in 1847 described this fracture. What we call this fracture? Monteggia fracture. Most commonly resulted from a fallen outstretched hand with force in pronation or direct trauma to the forearm. Fracture of the proximal or middle third of the ulna with dislocation of radial head and or radiocapitellar head, then causing this type of injury called Monteggia. So it is a fracture in the proximal ulna with dislocation of the radial head or radiocapitellar joint dislocation. It is comprised about 1 to 2% of all forearm fracture. The name from the surgeon called Giovanni Battista Monteggia. المختصر هي المونتيجيا fracture. It is described by this surgeon. على عكسه هو Galeazzi fracture. Galeazzi fracture describes a fracture in the distal third of radius with dislocation of distal radioulnar joint. The other fracture here in the first metacarpal called Bennett fracture. It is a fracture of the base of the first metacarpal, and this fracture, it is intra-articular, and due to muscle attachment, it tries to separate and displace segment. So this fracture needs open reduction and fixation. Bennett fracture. Lastly, what is called boxer fracture. It is a fracture of the neck of the fifth metacarpal, and usually after boxing injury or by a fist that direct the hand against the hard object, causing impaction of the head of the fifth metacarpal and causing a fracture through that side.